Dear viewers, welcome you all to our show, OSA, that is Orthopedic Solution Academy. Hope you all are well during this COVID-19 pandemic situation by wearing masks and keeping distance with each other. Dear viewers, today our topic is CTEV treated by Ilizarov Part 2. As you all know that CTEV is a very challenging topic for all the orthopedic surgeon, and we can manage it by Ilizarov. How we can manage it? And this is a very challenging topic also. And our honorable speaker is Professor Mofakharul Barisar. I would like to request Professor Mofakharul Barisar, the legendary Elizabeth surgeon of Bangladesh, to join with us. So welcome.
Thank you, Tanveer. Thank you, Tanveer, for your introduction. Thank you again.
Thank you very much, sir, for joining with us. Dear viewers, we have two academic panel with us. One is Professor Novikov sir from Russia. I would like to request Professor Novikov sir, the highly academic person, to join with us.
Thank you very much.
Thank you, sir. Good afternoon.
Good afternoon. Good afternoon. Добрый вечер. Кто учит метод Илизарова, пусть учит русский язык.
Thank you very much. Dear viewers, we have another enthusiastic Elizarov surgeon from Patna, India. That is Dr. Shamsul Huda sir. I would like to request Dr. Shamsul Huda sir to join with us. So welcome.
Thank you, Dr. Tanveer. Good afternoon.
Good afternoon, sir. Dear viewers, we have another speaker from India, that is Professor Agarwal sir, and he will join with us in the coming part of our program. Now, I would like to request Professor Mofakharul Barisar to share his screen with us and start his magnificent presentation regarding CTEV treated by Ilizarov. Professor Mofakharul Barisar, would you please share your screen with us?
Okay, thank you, Tanveer. My dear friends, especially Professor Novikov, then Shamsuluddin, and Ram Agrawal, and my viewers. Today, I would like to talk on the CTEV Part 2. Last Friday, I talked about the congenital telepathic virus, how to correct that one in an easy way. Now, the problems with the foot, if you see in CTEV, how you can proceed. I'll talk about that today. So these are the common slides that I love to show my places. And these are the places where I'm working now. So these are, 4 a.m. always I love to show. Now, Ilizarov method differs from traditional method into surgical treatment of the concept of deformity correction over time. The technical and biological opportunities to achieve deformity correction goal in traditional are frequently limited, but the Ilizarov method possesses great opportunities and advantages. What are the opportunities and advantages? The gradual and continued coordinated distraction of the bone and soft tissue permits to obtain lengthening of the foot. The influence of external force developed by Ilizarov device can help in desired form and size of the deformed foot can be created. During deformity correction, we can change the configuration of the device, and we can correct the errors that we are going to see during this distraction management. And what are the foot deformities? When you will we'll talk about the foot, you'll see the osteotomy of the calcaneum and talocalcaneal osteotomy, the middle part of the foot, and of course the osteotomy of the metatarsals. So now osteotomy procedures are closed and half closed. And what are the classification of the foot osteotomies? If you think about the osteotomy of the calcaneum, you'll see the body of the calcaneum or the posterior apophysis and the osteotomy of the subtalar area. Now, astragalocalcaneal osteotomy. Astragalo means talocalcaneal osteotomy, anterior talocalcaneal osteotomy, or dome or crescent osteotomy, and two types. One is V-shaped osteotomy, and another is Y-shaped osteotomy. Osteotomy of the middle part of the foot, osteotomy of the cuboid bone, and navicular bone. When we are talking about the middle part, then we must see the cuboid and the navicular bone, the tarsal bones, and osteotomy of the cuboid and as well as the cuneiform bones. Now, if we talk about the foot osteotomy, that osteotomy of the anterior part, and at the same time metatarsal osteotomy and osteotomy of the toes, phalanges, etc. So, osteotomy of the heel, calcaneal osteotomy. When we'll talk regarding the calcaneal osteotomy, we must have some indications. Calcaneal deformity in frontal plane, that means varus or valgus, and at the same time calcaneal deformity in the horizontal plane, that is, you'll see the adduction and abduction, and calcaneal deformities in the sagittal plane, that is, you will get the equinus or the vertical heel, and hypoplasia of the heel in complex congenital and post-traumatic deformities. Now, here, dear friends, you can see here the rectilinear osteotomy to correct the equinus with an increase in the height of the heel. This is very important. You can see here. This is, if you go for this osteotomy in this way, then this is the regenerate bone, and you will get a new regenerate bone here. And look at this, see this type, correction of the vertical position of the heel with lengthening. If you do a osteotomy here, then gradually you can go for lengthening in this way. So this is another view, another type of osteotomy of the calcaneum. Now, if you think about the subtalar osteotomy in the oblique plane, is performed distal to the side of the tendo-achilles fixation. Here is the tendo-achilles. You must remember that one. And this allows both correction of the flatness and increase in height the foot. See, this is a flat almost. Now, if you want to make the here, see the angle. In this way, you should have to go for distraction, and here you will get a very good regenerate bone. And this is, you can see, subtalar L-shaped. When you're going for this type of osteotomy, then again you are going for lengthening, and you can correct the heel height and a flat foot. So these are the different varieties of the osteotomies of the calcaneum. If you look in the picture, it will be very difficult for you to understand, but in the OT operation theater, this is not a very complex operative procedure. Very simple. If you are meticulous, if you have the idea regarding the anatomy, then you can very easily go for this osteotomy of the calcaneum. Now, horizontal subtalar osteotomy, look at this in combination with the triple joint fusion. Here, the triple joint fusion. See, look at this. He used the treatment of the post-traumatic flat foot or flat heel and hemimelic foot. Now, you can see how we can go for this osteotomy here. Then, here, you're wondering here, Huffring here. Very nicely, you can put the Huffring here, and then go for osteotomy. And gradually, if you go for distraction, you are getting a new regenerative bone like this. Now, this is, if you look from the outside, you can see it will be your eyes, in your eyes. You can see this is very complex, but this is not complex. This is the device configuration of subtalar joint fusion, and subtalar osteotomy of the heel. The subtalar joint, after resection of the joint surfaces, is fixed in a 5/8 ring. You can see here, 5/8 ring, support using the mutual compression of the bent wires. So this is your osteotomy. You see here, this is the line. When you are Huffring here, then go for distraction with hinges. These are the hinges. Then gradually you are getting a space, that is, you are getting a new regenerate bone here. So now, rectilinear osteotomy. Look at this. This is the talus, astragalus. This is the calcaneum, anterior appendix of the foot and neck of the talus. You can see, before going to do the osteotomy, you will just look at the at the X-ray in the OT room or in the Siam control. The tellers he used to eliminate a cavus foot. This is your cavus. See the angle here, to eliminate the cavus foot and to lengthen the anterior part of the foot. Initially, you just put your ring here and here, go for distraction. This kind of regenerated bone you are getting. And as a result, you are correcting the cavus and as well as you are getting lengthening of the foot. So, dear friends, now you see the performing a crescent osteotomy using a rectilinear chisel here in the close way. Make a small incision and a small lateral incision, and under the external malleolus, that means lateral malleolus. This is the lateral like osteotomy, and then look at this way and this way. Just you obliquely little bit go, then a straight way, then you go oblique, then you can correct the you can do regenerate bone here. Supination and pronation can be corrected in this way. Now, I told you in my initial classification, when you're going for V shape, this also lateral view, you can see you do a osteotomy here, take a calcaneum and a part of the neck of the talus. This is the V-shape osteotomy. Then here, if you put the two rings here,
Professor Barisar, we cannot see your slides
half
now.
ring here, and then in the foot.
Professor Barisar, can you hear me? I think there is a network problem and we cannot see your slide. Would you please share your slide again, sir? And recheck your internet connection.
One, you are sorry? Can you listen?
Sir, we cannot. Yeah, so we can listen you now, sir. We can hear you clearly, but I think there is an interruption in the past slide as because of the internet problem. Now the slide is okay. I think you can proceed on, sir, please.
Okay, now I'm going to the back one. Now you can see this one.
Yes, sir.
You can see? Yeah.
Yes.
V-shaped osteotomy, dome-shaped, then V-shaped osteotomy. You can see now?
Yes, sir. We can see you clearly, sir. Yeah.
But okay, a picture also. Okay, thank you. Then I proceed. Okay, now you can see here Y-shaped osteotomy has same indication as the V-shaped. When you are expert enough, you can go for Y-shaped or V-shaped. Indication is the same, but less time is needed for deformity correction and lengthening of the foot. You can see, you can prevent here lengthening of the foot. So why, when you are going for V-shape, this kind of osteotomy, before doing the osteotomy, just look at the picture. What is the situation of the whole foot? Now you can see your calcaneum and the relation of the feet metatarsal, and you are getting a Y-shaped, very good regenerate bone. So now this is the view of configuration of the Ilizarov apparatus. in astragalo-calcareal V and Y shaped. You can see very easy. Just from the lateral view, you can see here you have two blocks, one here, one here. Only the, playing with the wires, biocompatible thin Ilizarov wires. This is the V and this is the Y. So you can correct all these kinds of deformities with these two types of osteotomy, V and Y. Now, I'll talk regarding the metatarsal bone. Now, if you want to do the osteotomy, look at the kivas, look at the deformed foot. Now you go for the cuboid and navicular bone. We know this cuboid is related with the calcaneum and the navicular is with the talus. So, just in the lateral view, whenever you're doing in the OT, you'll see the siam, and under fluoroscopy, you can correct, you just do osteotomy like this, nothing to be worried about that. And then gradually you go for distraction. From this type of deformity, you can correct foot in this way with minimally invasive procedure. Now, see this one, rectilinear osteotomy of the cuboid and the cuneiform bone. We know we have three cuneiform bones here. Now you can see you have done the osteotomy in the cuboid and go the middle part. This is the cuneiform bone. And then you can go for distraction. You can correct your foot in this way. So now correction of the supination in front of the half ring vertical should be perpendicular to the longitudinal axis of the anterior part of the foot. In addition, the edges of the half ring are necessary to arrange the plantar surface of the anterior foot in a plane to resolve the supination. So this is the way you put your hinges here. Then when you are going for three biocompatible thin wires, when you are correcting this one, see, now this was a longitudinal one, this was a short one. Now this is the this type. When you are correcting, your fluid is in normal position now. So now open joint fusion between the internal cuneiform and bone and the base of the fast metatarsal bone, correcting the flexion and abduction of the foot. See how to do that? And while your foot is this in this way, how you can go for this correction of this one? You can do a dome shade osteotomy of the base of the feet metatarsal, this one. And you can correct from this to this way. Okay. Now, dear friends, you will get a lot of valgus, hallux valgus. Whenever I am talking about the deformities of the foot, this includes, you look at this, there are varieties of operations. This is, you can do this kind of rectilinear transverse percutaneous osteotomy of the distal part of the fast metatarsal. You can see here A and B. The distal fragment should be displaced outwards. Now, this is the distal fragment. You go for lateral side and you can put like this way. And with this, or you can fix it with mini Ilizarov with bow shaped here with Ilizarov apparatus, or you can go in this way. Now, I would like to share you my experiences with the different cases of the foot. Look at this 26 years old man, post-traumatic left ankle deformity, fixed equinus with 4 centimeter LLD and 2 centimeter raised heel. He came to me, young chap, look at this. His foot was like that. Now you can see 4 centimeter LLD with ankle deformity, fixed equinus. What you can do, look at the x-ray, look at the x-ray here. So it was very difficult for him to walk, and then came to me. I have done the Ilizarov, put the Ilizarov apparatus here. See, this is the half ring, this is the half ring. I have done the osteotomy here. You look at this. This is the red marking. This is the osteotomy. This is the radiographic view of the calcaneum. Lengthening is going on, and this is fixed. With this situation, He came to my center in 2015, and then I have done the lengthening. Look at this. This is the regenerate bone. Big widening of the calcaneum is clearly seen here. Now you can see here final radiographic view of the calcaneum lengthening. And then it was the before treatment. You can see here after removal of the Ilizarov apparatus. Now you can see the front view and back view of the patient after full correction. Look at this heel with the floor. And then see 6-year-old girl, post-traumatic right ankle and foot deformity with again fixed equinus, no heel pad, very bad scar. Look at this. This was referred from the Combined Military Hospital, daughter of a army personnel. And then look at this disorganized foot, ankle. Look at this, all these bones. If Ilizarov in your hand, if you go for proper way with maintaining the principles and philosophy of Ilizarov apparatus, then you could correct this kind of deformities. Look at these, almost 180. Look at this. And then short foot, painful walking. And then I decided to do the Ilizarov apparatus fixed during correction. You can see it was, you can see with placement before disorganized all calcaneum talus and tarsal bones. After suggested her to go for it, was also good clinical appearance of the foot. You can see. So Ilizarov can do a magical walk with pain-free foot. Now, 35 years old man with subtalar arthrodesis. This is a deformity of the foot again. See from the back side with varus, and if you see from the front side, you can see the heel here. And he was treated elsewhere, and then necrosis of the whole talus with the screws. And then came to my place. I fixed this. This is during treatment with the apparatus, and you must put the wires in the phalanges, and then gradual correction. Look at this radiographic view, and this is during treatment, and this is the almost corrected foot with subtalar arthrodesis. You can see here, good arthrodesis was done between the talus and the calcaneum with creation of the tibial joint space. Tibial joint space. Now we have done, this is, increase the space, tibial joint space, and at the same time fixation of the talus with the a little bit this. See the picture. This is the right one, this is the left one. Look at this. Deformity from the lateral side, from the AP, and corrected with Ilizarov. Hinges, fixed equinus. This is before, and this is after. Look at this. See this after correction of the fixed ankle equinus and deformed foot front and back view. Now, 18 years old girl, 2 centimeter shortening of the left foot. See here from the back side. Again, I have done this is the radiographic view of the short food due to short calcaneum. Right, normal food with normal calcaneum, you can see what we have done. Second post of our review day after see 2 months with two half rings and putting the wires in the phalanges and the metatarsal bones. This is the lengthening of the calcaneum and food is almost corrected. Now hills are in the same level, front and back view, you can see here. Now, 19 years old girl, see post-traumatic short and calloused ankle and foot. With this situation, painful walking, painful gait. And what to do? If you have Ilizarov in your hand, you can go for correction of the deformity and as well as the lengthening of the tarsal and metatarsal bones. Here you can see osteotomized foot osteotomy was done here and then gradual correction
Professor Bari sir, I think
you
there
know
is a network problem and we cannot hear you properly, sir.
ugly. So this is ugly.
Dear viewers, we are facing some sort of network problem and hope we'll overcome within a few minutes. Today our topic is, you know, that the CTEV treated by Ilizarov as well as the different type of osteotomies in case of foot. And our honorable speaker is Professor Mofakarul Barisar. And we have another very learned speaker from India, that is Professor Agarwal sir. And after completion of this presentation, Professor Agarwal sir will start his presentation. Professor Mofakarul Barisar, can you hear me, sir, please?
Yes, I can hear you. Can you hear me?
Yes, sir, we can hear you now, sir, but we think we missed last two slides as because of
Two
network
slides.
problem. Yeah,
Now you can see
last,
this one.
yes, sir,
You don't see?
we can see your slide clearly and we can hear you loudly, sir.
Okay, it's good. Why? Now you can see here brachymetarsal bone, fourth one. You can see this one.
Yes, sir, please proceed on, sir. It is absolutely clear now, sir.
Okay. Now clear. Now you can see here short foot metatarsal. Whenever we are talking about the foot deformities, patient will come this kind of deformity to you, and then how to proceed? See, with mini Ilizarov fixator, just put the wire like that, and then go to the first and second wire. Now you can see here this is the lengthening part, and then finally you can see here the from this situation to that situation with Ilizarov when we remove the Ilizarov apparatus. Now you can see the hallux valgus deformity. This lady came from USA to treat in our country. Dislocation old. See here. See here. It was like that. All the toes were clawing, and then I have fixed, open it up a little bit, and then correction of the foot, and then you see I have after 3 weeks follow-up. This is the final follow-up from this situation to that situation with Ilizarov apparatus. And she was very happy. After 2 months, we removed the Ilizarov fixation apparatus. This is Helix valgus. I told you. See, Helix valgus of a deformity with hovering or bows like that. And you can see easily, you can correct, see how I have done this one with a bar here and two bows are here with Oliver, and then we have removed
Dear viewers, today we're facing lots of internet jamming, so it's hamper our regular presentation. Professor Mufakarul Bari, sir, can you hear me, sir, please? Dear viewers, I think we will come back within a very few minutes. And during the interval time, I would like to request Professor Novikov, sir, to say something regarding the osteotomies of food and the club food management by Ilizarov. Professor Novikov, sir, would you share your valuable knowledge with us? Sir, we cannot hear you. First, you have to unmute yourself.
And just now?
Yes, sir. We can hear you clearly, sir.
Oh, thank you. Good afternoon, everybody. And osteotomy on the foot give orthopedic surgeon possibilities go away from any component deformity of foot, like for adult, and just now we slowly start to use osteotomy and arthrodesis for child. Very seldom, but with shortening, with lengthening, sometimes we do that. And osteotomy, bone on the foot, very interesting and very delicate area for surgery. I think doctor from India and Bari can say this is more difficult than lengthening, for example, tibia, humerus, or femur. But result is great. And I am just now very impressed and very happy because Dr. Bari show great magic result. And I am a little bit sad because in the Russia, only few doctors use osteotomy for treatment deformity and problem on the foot. And I am happy with your activities with doctor from India, young doctor in the world will use Ilizarov technique for treatment problem on the foot. Thank you.
Thank you very much, sir. Sir, do you have any post-operative follow-up in Russia regarding the osteotomies of foot?
Usually we finished lengthening and correction deformity on the foot in front of our doctor. We are happy because I work in the government hospital, and patient can possibilities state all period of treatment, active period of treatment in the hospital. When we finish lengthening, and usually patient need near 40, 50 days. This is depend of age and depend of amount of lengthening. Then patient go home, and sometimes we lost result because patient remove the frame, remove the apparatus, not in front of us. This is problem. If we start, we need finished. And another problem, who will follow, because surgery is surgery, lengthening is lengthening, but patient need rehabilitation. And still in the Russia too, we have, this is problem. Who will support this patient between finished of lengthening and remove of frame? Dr. Agrawal, in your clinic, after finish of lengthening, where your patient wait final result? At home, and maybe sometimes come for checkup in front of you? I not heard you.
Yeah. Okay, sir. Main problem is when you keep our patients till we are doing lengthening. And after that, mostly patient we send their homes. And nearby a lot of cheap hotels. So lot of patients, they stay in the surroundings because there is a lot of problem of the infection, wire infection. So to avoid that, lot of new hotels, very cheap hotels has been developed in surrounding areas, and they stay there and usually come there because main important is the follow-up. So if there is no follow-up, the results are not good. The problem in the Ilizarov technique, number one, what is the problem in India? They don't walk. A lot of relations are there, so they don't do the exercise. So, because if the patients are not doing the exercises, what happens? Vascularity is not proper. The calf muscles hang there. So, it is very important in our country that the people do not do the exercise. They have an idea, okay, if the ring has been applied and it is a magic, our bone will unite. So, but the bone will unite when you will eat chicken, fish, and you will do the exercise. That is most important. So, I suggest most of the patients they stay in surrounding areas and come for exercises. That is the main secret of the Ilizarov. Okay, sir.
Thank you, sir. Thank you. Thank you very much, sir, for sharing your
And
valuable
can
knowledge.
I little bit continued? But
Yes, sir,
please
please.
wait, because you see, during so many months we show different techniques, excellent surgery, perfect result, but this is very big time
Thank you very much.
surgery, between surgery and finished of treatment. And patient need only one surgery. But patient with our frame, with Ilizarov frame, stayed, continued life during big period. And we not talk about that. Only exercise, only rehabilitation. What is it? Rehabilitation after lengthening of the foot. Which kind of support patient need? Because just now Dr. Agrawal say about complications with infections. Why? Maybe little bit clean, and this is problem go away, because patient without our information, without our control. This is problem in the world. Why we have so many opponents and so many doctor against our methods, because oh, this is infection. This is not infection. This is patient lost our attention, and patient haven't full information about what he need to do at home. because very easy. Go to the bathroom and little bit clean. Sorry, please continue, Dr. Barry. Your presentation today is great.
Professor Barry, sir,
Barry.
can you hear? Professor Barry, sir, can you hear us? I think again there is a jammed internet problem. I think I would like to request Professor Agoral sir to start his presentation, and after completion of his presentation, we will discuss the matter. So I would like to request Professor Agoral sir, would you please share your screen with us?
Okay, sir. Hello.
Yes,
Are
sir,
you
we can
hearing
hear
me?
you, sir. Yes, sir,
Okay.
we can hear you clearly, sir.
Basically, after
I can hear
working
you.
for 25, 30 years, we have came to conclusion that open surgery is obsolete in club foot, because about 25, 20 years back, a lot of cases has been operated. Still, people is operating because the problem is they do not learn the Ilizarov technique. So lot of surgery is performing in India, all over the world. A lot of complication occurs. So we have made the idea protocol that open surgery is obsolete in club foot. We'll show you how we are telling that. Are you seeing me, sir?
No,
Hello?
sir. No, sir. We can't see your slide, sir.
Okay,
Could
okay.
you
Just
please?
a minute.
Ну вот этот ярд-стрим, мать его, блин. То слышим, то не слышим.
Now you are seeing my slide?
Yes, sir. We can see your slide, sir.
Okay. So should I start
I
that?
can see.
Yes, please, sir.
Okay.
Please.
Okay. So after doing a lot of work in 25, 30 years, lot of surgery has been, open surgery has been done. A lot of club foot has been spoiled. So we now came to conclusion that open surgery must be obsolete in club foot. We are showing the how I will prove that. Are you hearing me, sir?
Yes, sir. We can hear you clearly and loudly,
Yeah.
sir.
Okay. So basically, the thing is that a lot of people who are correcting the club foot deformity, they should have a clear cut, because this is a 3D pictures showing the deformity in 3D. So we have to look after the photographs by frontal plane, then sagittal plane, and then horizontal plane. So we'll show you in the frontal plane. They say there is a pronation of the forefoot in comparison to the hind foot. Initially, lot of people say, "Oh, there is a supination of the forefoot." So what happened? That is the most which the Ponseti has told, that there is a pronation of the forefoot. If you compare with the hind foot, you can see very well it here. Second deformity is the adduction of the forefoot. By that, you have to take the photograph, the plantar view. Number third, you have to take the photograph from the back, the frontal view from the back, there is a varus deformity. And number four, you have to see the photographs, X-rays from the side, there may be the cavus and equinus deformity. This is a child, Ponseti has shown. You can see what is the problem in the club foot. This is the talus, and this is a navicular. So what happens? This navicular should come here, and this is the extensor digitorum, and this is the extensor holicis longus. So what happens in Ilizarov? Until and unless you do not do the supination, so what will happen? The ball, this is a ball socket joint. If you are promoting the forefoot and you are trying to supinate and abduct the foot, it will not come. That is the basic secret of the Ponseti technique for the correction of foot. Still in our country, lot of people they are abducting, but they are not supinating. So your first plaster, whatever surgery we do, there should be supination of the forefoot. And after that, when there is a supination of the forefoot, so what will happen? Navicular, it will come into the socket. Otherwise, whatever try you can do, the navicular should not come into. So basically, correction of the clubfoot, one should have the supination of the forefoot. So we have done the study in the first Cadbury study was done. So there are ligament on the medial side, tibio-navicular ligament, tibio-calcaneal ligament, and posterior tibio ligament. So what happens? These, and this is the plantar calcaneal ligament. So what happens? These all ligaments were contracted on the medial side. But what initially we used to do that, we used to open that and cut that, but they used the fibrosis. So what happened in the Ilizarov technique? We gradually distract these ligaments. And there is another study that is the posterior tibiofilar ligament, calcaneofibular ligament, and anterior tibiofilar ligament. These all ligaments are contracted. So the advantage of the Ponseti is Ilizarov technique is that gradually we distract these soft tissues. Number third, we have shown you there is a lateral side. Main notorious is the talocalcaneal ligament, interosseous ligament, and this is anterior tibiofilar. So one way to correct the deformity, they should have the proper knowledge of the ligaments and which ligament has to be stretched there. Most notorious is the this plantar ligament. What happens when this ligament is contracted? So it produces the pronation of the forefoot. So whatever surgery we do, we cut it. This is I'm showing the cut in the plantar. This I'm showing you that whatever surgery you do in clubfoot, you cut the plantar ligament at the just close to the calcaneus, because otherwise calcaneal artery is being forward there. So this is a basic principle of the clubfoot. You have to cut this ligament. Otherwise, how much distraction you will do, you cannot correct the clubfoot. So initially what we do, as I have shown here, we cut this ligament here by percutaneous. So our treatment of the 0 to 2 years Ponseti corrective cost, 2 to 6 year MICC, which will show you, and more than 6 year Ilizarov based on Ponseti principles. So 0 to 2 years serial Ponseti cost, followed by T8 anatomy. So most orthopedists agree that the treatment of clubfoot should be non-operative because surgery in the clubfoot is invariably followed by deep scarring, which leads to retracting fibrosis and leading to recurrence of the deformity. So mainly question is asked when to start the manipulation. Just after birth you can do that, and never promote the foot. Long leg cause is the word. In the last, equinus is corrected. So this I am showing you in the same principle. I am showing this in the same principle. When you are correcting the clubfoot, you have to supinate the foot so the navicular should come into the talus head. So when this is the mechanics, when pressure is applied over the head of the talus and foot is abducted, the navicular abducts along with the cuboid and calcaneus. Abduction of the calcaneus lead to eversion of the calcaneus as soon as it comes out from the undersurface of talus and correcting the heel varus. So the motion start at the talonavicular. This I'm showing you. So we have shown you just ponsity plaster, how beautifully the deformity is corrected. So one have to take the photograph, the adduction, how it is corrected in 5 plasters, and varus is corrected in 5 plasters. So equinus is the last deformity to be corrected after correcting varus and adduction. In most of the cases, tendinochleus is very tight, so stretching is not possible, especially in the neglected clubfoot. So I'm showing you how the deformity is corrected after tenotomy. The question arises when to do the tenotomy. When foot is abducted, adduction is corrected, healing valgus. So it's a very simple technique. We use 2% local there and just take the 15 number blade. This I'm showing you because in a lot of Indian orthopedic surgeon, they do not know how to do the correction with the Ponseti technique. So what we have in one of the cases, we have studied the open the tendinochleus. What was the difference between when you use to jet plasty and we use the percutaneous sternotomy? Because in this case, we have not disturbed the paratendon. So you can see that we have taken this picture after the 6 months of the sternotomy. Very good regeneration takes place. That is the advantage of the percutaneous sternotomy. So we say, do not open the jet plasty or open because paratendon is destroyed and it leads to fibrosis. So mind you, this is my suggestion. The never opened by jet plasty the tendinochleus. These are the braces we are given. You can see the how beautifully physiotherapy is very important there. And this is 20-old boy. After 15 months, you can see the how beautiful is corrected. After 18 months, and this is after 7 months. So now we are going to neglected for 2 to 5 years. So I told you the plantar fascia is very notorious. So step 1, you have to do the plantar fascia cut, then plaster cast in the last particular sternotomy. You can see a boy 2 years 7 months, very severe deformity. So we have cut. This is a percutaneous technique. We have done the plantar fasciotomy, and after that, mostly deformity is corrected. And after that, we have done the DA sternotomy. You can see the beautifully deformity is corrected. In the same way, 5-year-old child deformity is fully corrected. You can see the plantigate foot is there. Sometimes we need the adduction. So what happens? We apply the frame and correct the deformity. So in the same way, the deformity is corrected. Now we are coming to the neglected clubfoot by Ilizarov external fixator. We have seen a lot of cases. I was in the visit at Agra. The case has got the open surgery. Still, I tell you, some of the centers are doing the open surgery. You can see the Scott. Until now, Lord the word, the calcaneus is picked with the wire during Ilizarov correction of clubfoot, violating the Ponseti principle, leading to inadequate correction. Most orthopedists agree that the treatment of clubfoot deformity should be non-operative because surgery in the clubfoot is invariably followed by deep scarring. The abundant scar tissue formed after surgery leads to retracting fibrosis, which further leads to the occurrence of deformity. Thus, it is advisable to do the minimum surgery. Ilizarov external fracture can be used in older children or those with very stiff atypical clubfoot because the fixator is versatile and flexible in application. During the construction of the frame, we have applied the principle of Ponseti in Ilizarov. So our first step is to correct the pronation of the forefoot, then metatarsal retraction in the last equinus. You can see it's a very simple procedure. We give the foldings because without that it is not possible to correct the pronation. And this is a Cadbury study which have shown question arises where to put the olive wire. So it was just at the base of the head there. And these are the 2 wires here, 2 wires here. This wire is first and second metatarsal. This wire is 5th, 4th, and 3rd metatarsal. So gradually, what I told you, a lot of ligaments are there. So we have to do the suppling of the ligaments by gradually distraction, minimum 4 to 5 millimeter of distraction. After that, we change the rod, it gives the 10 degree of the supination. And after that, when the deformity is corrected, we correct the adduction. This is the diagrammatic picture there. So this we have shown the cadaveric that whenever the abduction is produced, the heel become invalgus. This is a boy, 19-year-old boy with bilateral clubfoot, very severe deformity. So what we have done, you can see that how much deformity is there. This metatarsal and tarsals, there is about 90 degree is there. So what we have done in these cases the osteotomy. This is a talocondylian osteotomy. So mind you, this osteotomy is from the sinus tarsi. So we do not disturb the subtalar joint. I tell you, without osteotomy, what we do, we take the wedge from here, and after that, we reverse that wedge there. We do the osteotomy, take the wedge, and we reverse that. So that what we do, we push that wedge on the medial side. So until and unless, because on the medial side there is so much soft tissue contraction. So we find in many years that without talocalcaneous osteotomy, I tell you, there is a lot of studies on the V osteotomy, but I tell you, it's very difficult to distract from the medial side because there is so much soft tissue contraction is there. So in many years we came to know that the whole thing is done the percutaneous inverted V osteotomy and remove the wedge from here, from the rear. That wedge we take and we reverse that and we push that wedge on the medial side. You can see that this boy who is having the severe deformity, we have taken the wedge from here and here. Taken the wedge there. This we are showing how we have done it. This is we do the whole thing is done the percutaneous. So what we have done, we have taken the wedge, we have done the spreader there, and we have removed that wedge there. And after removing, what we do, that through the talus heel lower left corner, the incision were made over the sinus tarsi. We take care that our incision should be sinus tarsi. A greatly angulated wedge was excised from the neck of the talus. A less angulated wedge had been removed from the calcaneus within osteotomy. So what we do, this is the wedge, we have done the spreader, and after that we spread that and we reverse that work and we push on the medial side. So the deformity is very well corrected. In the same way, when we do the wedge there, first of all we apply the frame here. And after that, when you apply that frame on the tibia, so what happens? Then we have applied the wedge osteotomy here. You can see that. And we try to see that how much deformity is corrected. The size of the wedge depends on the deformity. If deformity is more, our wedge size we will. And after that, you can see that we have initially it was a very severe deformity. So we have cut the wedge and correct the deformity. And after that, we apply the frame and try to correct that deformity. So you can see that gradually post-operative photographs is there. And in the last, these are the X-rays are there. And in the last, you can see, you can't imagine how much is the magic of the Ilizarov. And when you do the calcaneo talastostomy, plantigrade foods is there. And you can see there how much beautifully the deformity is there. This is the final photograph, the deformity. Here the only thing is the some flat foot has come, but it is having the good arch there. This is a young girl, 9-year-old girl with the right clubfoot deformity. The same principle, calcaneo talar osteotomy we have performed, and the beautifully deformity is corrected. This is another girl who has been operated 3-4 times. So same calcaneal talar osteotomy we have performed there, and beautifully the deformity is corrected. This is 18 girl, old girl. You can see the how many surgery has been performed. So we have done the calcaneal talar osteotomy and deformity is fully corrected. This is a neurogenic case. It's a very severe deformity. The boy is having the meningocele. In all the neurogenic case, we have to do the osteotomy and the bony. So in the same way, we have done the calcaneotalar osteotomy, remove the wedge, push the wedge on the medial side. You can see the how much severe deformity is there. He was ready for the amputation, so we told that we'll do your Ilizarov. And in the same way, we've applied the pigs there and applied the frame, and gradually we have done the distraction. I tell you, you should have the knowledge of the ligaments. So we have to make them distraction. In the soft tissue, we can do the distraction up to 3 millimeter per day. So gradually we have deformity, and you can see the beautifully all the deformity has been corrected. So it's a marvelous technique. In all the cases, once you do bony surgery, osteotomy, and gradual correction, they can very well we can connect the deformity. You can walking with some support there. It's a boy, 14 years boy, having a very severe deformity here, bilateral. You can see that. You can see that in this era, we are getting the cases like this. So what we have done under local anesthesia, we have done the plantar fasciotomy there. Just we have rotated the 90-degree. Number 15 blade is there. And after that, you can see the tendon is very tight. So we have done the inverted VY plasty. VY lengthening of the tendoachilles is shown as fresh cut work. A midline incision at the lower end of the gastrosoleus muscle belly, over which the tendinous sheet is lying. Inverted V cut is being performed. Complete inverted V cut. Cutting of the last tendinous fibers. You can see the last tendon fibers there. The tendon get lengthened while surgeon apply passive dorsiflexion. We are doing now no jet plasty. We are doing the VY plasty because number one, sometimes in cerebral palsy and other things, if there is a recurrence, we can do the tenotomy. I tell you, this is VY plasty is an excellent technique. So I'm showing you how we do the corrective test. It's a very simple. Just you take the two rings, calculate that, put one wire over here. This wire you can fit that, and after that you fix this frame. After that, another wire is there. So this frame is stabilized there, and after that we put the four wires, two wires here and two wires. It's a very simple technique. Just you see this photograph, you can perform your own. Then we use the tensioning of the wires, and after that we apply the frame full rings there. We make the frame. After that, you can see that we applied the frame and just give the rotation there. This wire is given to the talus, only wire is given over the head of the talus. Gradually, we are correcting that deformity, and you can see that beautifully the deformity is corrected. This is a plantar photograph there. So I have written a book. That is book is distributed in the course material at participant in 44 countries. And most of the world, this book is distributed. This book is given to the Ponseti also. And the period of study was 2000 to 2018, 0 to 2 years with Ponseti 945 cases, 0 to 6 years with MICC 51 cases, and more than 6 years Ilizarov we have done the 57 cases. So conclusion, Ponseti cost is standard treatment. For clubfoot 2 to 6 years we recommend the MICC. for neglected club for more than 6 years. We recommend Ilizarov based on positive principle. We should pass the word to tell us not calcaneus. The series the club food power the largest in India. We recommend that open surgery is obsolete in club food. I got the national award. This award is given to one person in India. National Award for the Welfare of People with a Disability 2000. You know how we came to learn this technique. We do lot of free camps for last 2000. So we correct these clubfoot children. So there is a hospitals are there where we can correct the deformity. Otherwise, we take all these children to our hospital and we apply the rings. So by these children, they have taught with the biomechanics there. Thank you very much, sir.
Thank you very much, sir, for your excellent and amazing presentation. Now, I would like to request Professor Mufakrul Bari, sir. Sir, do you have any questions or do you have any suggestion regarding the presentation? As we miss your last part of your presentation as because of the network problem. So I would like to request Professor Mufakrul Bari, sir, to share his knowledge.
Thank you very much, Ram Agarwal.
Okay.
Very good presentation. You showed all the difficult cases. Same situation in our country, your country, late cases we are doing, neglected and relapsed. Those who are opening the case, still the most of the old orthopedic surgeons they like to open it up, PMR and open surgery, and that's why relapse cases you are getting. So you rightly showed everything that plantar fasciotomy, you should have to go for that. And even then, in my last lecture, I told with AMC, CTEV is very difficult to correct. Even 2 years, 3 years, I go for Ilizarov. Not I don't wait for 5 or 6. And the children always, they take it very easily. And gradual differential distraction gives very good, fantastic result with Ilizarov. And you can correct whatever you like, you can do three-dimensional correction. And you showed all the cases that last in my last Friday. I also showed the difficult cases. Today my lecture was the only regarding the osteotomies. Thank you very much for your sharing the good cases. Okay, thank you again.
Dr. Bari, can I speak there?
Please,
Yes.
sir,
Hello?
please.
Yeah, actually, I was surprised to see that in this era of 2011, I have written book in 2000, lot of old orthopedic surgeons, they are performing the open surgery. A
Yes, I
lot of
told you.
complications. So I'm surprised to know, and they are not even initially they are following the Ponseti technique. Lot of cases come to me. Thus, a 12 plaster, 15 plaster has been given to me. I do not know why people are not learning the technique. And Ilizarov is
Oh,
not such a good, very, very, very good technique because all the fixators they are very weak. I tell you, the popular fixator in India. In my one of the cases, my one of the camp, we applied the 20 that fixator. And in some days after found that I have spoiled that 20 children. So it needs a stable fixator. And the small fixator, this and this, lot of people are doing that fixator. They doesn't work, I tell you. So I told to them, I asked to them, you never shown your result after 1 to 2 years. But we have to see the record of the cases. So we are getting lot of fellows. Still the one fellow is sitting where they came to in Corona. And I tell you, our aim is to teach and teach to orthopedic surgeons. And even then 2021, some of the surgeons have not learned that technique. And it is very disgusting to me. Thank you very much.
right. It's like rightly you told. I know the even the pediatric surgeons in India. Most of
Yeah,
they are my friends. They're not doing this, Elizarov. Why? I don't know. I don't understand.
yeah.
They are cutting. Pediatric, well known. I know
Yeah,
them.
yeah,
Pediatric orthopedic surgeon. They don't use this Ilizarov.
yeah.
So
I told you why, because Ilizarov,
and problem is whenever you are going for cutting, you will get adhesion. This is
yeah,
obvious.
yeah. So I told open surgery should be obsolete in club foot. This should be mandatory.
Mm. Thank you.
Thank you very much, sir. It's a great day as because of two legendary professor discuss about the CTEV in front of us, and I think we can learn many things from their discussion. And the main take-home message is, don't open the CTEV.
Yeah, yeah,
Please
Exactly.
try to follow the Pond City method and followed by the magical Ilizarov, and
yeah.
it will
PNR
give
is
the
obsolete.
ultimate result. Yeah.
Okay,
So
thank you.
I think we are at the end of our program, and I would like to request Dr. Shamsul Huda sir to say a very little speech regarding our today's program.
Thank you, Dr. Tanvir. It was really great learning from both of my masters, both of my legendary teachers. It was really great. I'm regularly doing Elizaro, our club foot, yes, our club foot, but there was a lot of learning today and again, next year again, I'll learn again. So this was wonderful learning. Taking a short of time we're spending here. Thank you, sir.
Thank you.
Thank you very much, dear viewers. Hope you learned the main thing that don't open the CTV case. Try to
Yeah,
do it by Pond City, then followed by Elizarov.
yeah,
And
yeah.
I would like to thank the Raj TV for helping us to do this type of academic program. And definitely, I would like to thank Renata Pharmaceuticals Bangladesh Limited for sponsoring this program. And I am Dr. Mahmoud Tanvir Ashraf saying bye bye to all of our viewers today. And hope we will see you in the coming Friday with another topic regarding the Elizarov. Till then, I would like to say bye bye to all of you. Bye bye.
Thank you. Bye bye.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe.